It is with great pleasure that I introduce to you this morning Dr. John Broderick. Dr. Broderick is a child and adolescent psychiatry fellow at Phoenix Children's. He earned his undergraduate degree from UCLA before completing his medical degree at the University of Arizona College of Medicine, Phoenix, followed by his psychiatry residency at Banner University Medical Center, Phoenix. Dr. Broderick has a particular interest in pediatric catatonia and is currently involved in research examining hallucinations in children admitted to the inpatient psychiatry unit. Please enjoy his talk today titled Pediatric Catatonia, Recognition, Workup, and Treatment.
All right, thanks, Dr. Whitfield. Hi, everyone. It's nice to meet you today. My name is John Broderick, and we're going to talk about pediatric catatonia. Just a technical switch here. Let me go ahead and start my presentation and then share my screen. So bear with me here. Share screen one. Alrighty, so does that show up? Maybe Dr. Whitfield, can you see that?
Like that.
Right. All right, so good morning, everyone. Thank you all for being here. It's a privilege to present here to this group that spans multiple specialties here. Again, I'm one of the child and adolescent psychiatry fellows at Phoenix Children's, and I picked this topic today because it's one that it kind of kept finding me as I've started training here at the Children's Hospital after finishing adult training. It's both I've encountered it when rotating on inpatient units, adolescent units, and then also on our consult service here. And so it's always interesting to kind of refresh or learn about it. And then each time there's something else I also pick up when I go back to research more. So specifically, we're going to talk about pediatric catatonia. It's going to be an overview of how to recognize, how to work it up, and how to treat it. I'll try to provide some of the latest literature on this. Some of it too is, related to the neurological parts. So I'm not going to pretend I know everything. I'm not a specialist in neurology, but I think it's very important that we work together on this, and I'm going to try to bring some of that literature in. And so without further ado, let's begin. So these are my overview, my learning objectives today. I built this around 3 goals specifically. We're going to look at the evidence, the epidemiology, neurobiology, the guideline recommendations, how that's an evolving picture and should shape what we do clinically across all our specialties. Second is to be able to tell pediatric catatonia apart from the conditions that look like it. There's the DSM criteria that we use. There's rating scales that can help with that. And then the lorazepam challenge, which is what we use generally for diagnosis and treatment, or help with treatment afterwards. It does, as we all know, overlap with a number of neurologic and psychiatric conditions. And a systematic approach is kind of what turns, hopefully, our recognition into something that's more reliable, recognition from a guess into something that's more reliable. And then third is a stepwise evidence-based approach to treatment, which includes benzodiazepines. There's also ECT when benzodiazepines aren't enough. And then there's other adjunctive options as well. So what I'm hoping today is that everyone leaves with at least one concrete thing they can use the next time you have a pediatric patient with unexplained psychomotor changes. So, and that kind of brings me to this next primer slide. Before we go further, a quick anchor, just so everyone's on the same page. Catatonia, generally, it's just so everyone knows, it's a neuropsychiatric syndrome, disordered movement and behavior. The key word is a syndrome because it usually sits on top of something else. Mood disorder, psychosis, maybe a neurodevelopmental disorder, but also other etiologies like autoimmune encephalitis, metabolic issues. And so rather than being a disease, looking at it that way can help. And for a lot of the 20th century, we'll go over here, it was treated as a subtype of schizophrenia. So we'll talk about that too. Practically, the DSM-5 text revision, so the most up-to-date version of the DSM, asks for 3 of 12 features And we'll go over those too for diagnosis. We don't need to know all of them offhand, but it's also coded in one of three ways now. So it's associated with catatonia with another mental disorder, or due to a medical condition, or unspecified catatonia. So I think what I'd like everyone to know is that it is a psychomotor behavioral syndrome, and that it's far more common than I think we assume usually, and it's treatable and largely reversible if we can catch it early on. So moving forward, starting with the historical overview, a lot of it traces back to some nosological decisions, like how to classify it. And so that's what I wanted to touch on first. So Dr. Kalbaum first described catatonia on its own syndrome, like 1874, around that time. Even in his original adult patients, most had their first symptoms back in childhood or adolescence. And so he gave trauma a central role in the younger patients, and something that the field largely didn't really address because for the next century, because in 1896, Dr. Kreplin folded it into dementia precox, which is kind of essentially what we call schizophrenia now. Bleuler also echoed that and carried it kind of through the first couple editions of the DSM. And so for a few generations, catatonia kind of stayed linked to psychotic illness. And that's, how we understand a big part of why maybe it was underrecognized for so long, just in theory. The correction, or where we got to today, came in stages. So Fink and Taylor argued, like in 1991, so this was just before the DSM-4 came out, that catatonia shows up across many illnesses and isn't simply just a subtype of schizophrenia. And the DSM-4 in 1994 added catatonia due to a general medical condition and catatonic features specifier, though it still kept it a catatonic subtype of schizophrenia. In DSM-5, which came out in 2013, they dropped this subtype and recognized catatonia associated with another mental disorder, medical condition, or unspecified. ICD-11 coding actually goes a little further and names catatonia and independence syndrome, the subtypes that emphasize autism, substance or medication-induced catatonia, secondary medical catatonia. It adds autonomic specifiers. And then also Lienhardt's work in 1950 on childhood catatonia in children with developmental delays was also one of the earliest attempts to separate catatonia from autism in young patients, which is a distinction that I'll touch a little bit on today because I've started to work with that as I've worked at the Children's Hospital. So there's a real debate about how many signs you need, but the DSM-5, as I talked about earlier, asks for at least 3 of 12. But in one validated series of there is only about 73% of true catatonia cases that actually met DSM-5 criteria. And so DSM-5 also won't allow for the diagnosis when delirium is present, and there isn't much evidence behind that exclusion. It's just that's something that they put in the criteria there. And there was a prospective study of 136 critically ill patients where 31% met criteria for both catatonia and delirium. So moving the Bush-Francis threshold, which is also a screening scale we'll talk about, to from 2 signs to 4 signs gives us more sensitivity. So what I'm saying here is sometimes there's not an agreement on it. The DSM-5 likes to have 3, so we can call it a diagnosis. Bush-Francis, you'll need 2, which we'll talk about. But then we look at the data, sometimes patients, they don't read the textbooks. So for epidemiology, this section I just want to talk about, really there's 4 numbers. The first is, and this comes from, and you can see here, and this jump here, it's just a little bar graph from 4 to 10, but essentially this comes from Dr. Lichter's group at Boston Children's. They looked at 6 years of psychiatry consults, and the rate rose from about 4 per 1,000 to nearly 10. So again, this is per 1,000 patients on the y-axis here. but it was a statistically significant increase. And then also Dr. Smith's team at Vanderbilt, who we'll talk about later, they saw a tenfold rise over the same period. Why this is happening, one proposed contributor was the neuropsychiatric sequelae of COVID-19, possibly. Second number that I want to touch on is the increase in mortality. This came from Dr. Cornick and colleagues. It was a 2009 study, but it followed 35 adolescents, so N equals 35. But catatonic schizophrenia for about 4 years and found markedly elevated mortality, so including death by suicide. So it was only a prospective pediatric mortality study, but it was something to touch on here. And then also, third, using the kids inpatient database, Dr. Lucarelli's group identified roughly 900 pediatric discharges in the US in 2019 carrying the catatonic diagnosis. And the mean age was about 15 and a half, actually. So, but nearly 10% were under 13. And there is a case report of a documented case in a child that was under 5 too. So it isn't only a diagnosis of adolescence, but again, rarely seen with younger kids. And then about the etiology, when a child's catatonia has a medical cause, roughly 70% of the time it can be an autoimmune encephalitis. And that can be associated with like abnormal EEGs. There's also, this comes from like a mixed age group, but with older patients, we can have DVTs when they have that hypokinetic subtype as well. So talking about the history, some of those statistics, moving on to the clinical presentation. Recognition is where it becomes useful at bedside. And sometimes the hard part is that catatonia is very subtle, or at least I'm finding that, and that across specialties, it's really hard to look for it if you're not, thinking about it. So going over the criteria here, to give you a clinical case scenario, think about you have a 12-year-old referred to your clinic, possible seizures. She's been staring blankly for 7 days. She won't speak when spoken to, even though her parents say she was conversational and engaged just 2 weeks ago. She sits with her arms in her lap. And when you gently lift your arm, it stays where you put it. MRI is unremarkable. Her EEG is pending. What's on your differential? So when we think about catatonia, again, the DSM-5 TR defines catatonia by 3 or more of the 12 features here. In catalepsy and waxy flexibility, so catalepsy, what I was just talking about, are signs that everyone kind of thinks of, I think, traditionally when we think about catatonia, but it's actually one of the least common in children. Dr. Smith and colleagues, so this was in 2024, they had like a cohort, a multi-site cohort of 143 pediatric patients, found that waxy flexibility was in fewer than 20% of the cases, along with like Gegenhalten and Angel pose, or Wittgen. So that's the Angel pose lamp, passive obedience. And what you're far more likely to see are features in the lower rows of this table here. So like staring, mutism, immobility, withdrawal, posturing, and each is present in more than half the adolescents in that cohort they found. A key diagnostic principle that was stated in the is stated in the DSM-5 TR, and is also reinforced in guidelines we'll talk about later. So the APA guidelines and BAP, is that 3 or more of these features makes the diagnosis regardless of the underlying cause. So you don't need to know the etiology before you name the syndrome here. And Dr. Wartzel, who works with Dr. Oldham at University of Rochester, had a 2021 study that even among psychiatrists and psychiatry trainees, medical students, participants correctly identified only about half of the relevant features on a standardized online assessment. So there is, recognition of this is very subtle, even in psychiatry. And so I think what, on this page, we want to think about what are the full criteria? What do we think about or what comes to mind at first, but it's not always something like waxy flexibility or catalepsy. It can be other symptoms as well. Specifically pediatrics like features and subtypes. So it has some features that are either more common in children, which I talked about, in the 2025 APA resource document on this. So this is the American Psychiatric Association, points to incontinence, automatic compulsive movements, schizophasia, so like disorganized scrabbled speech, acrocyanosis too. I had one of my attendings in the CL service talk about that, like anytime maybe a patient starts to become incontinent or regress, that maybe we can start thinking about it. It's not 100% specific, but psychomotor regression is especially important in younger children. A toddler who looks like they've lost developmental milestones, who is speaking in sentences and now is mute, is walking, is now immobile, maybe not be having a primary neurodevelopmental regression. Maybe it's a catatonic episode. The three subtypes worth recognizing, which we talk about this too also with adults, are hypokinetic, excited, hyperkinetic, and then malignant. It's in red because that can be a medical emergency too. Hypokinetic stuporous, I think, is something that we all think about, maybe just from like media. And then hyperkinetic can look like an agitated delirium. So that, makes it an important differential in an acute medical setting a lot of times. And then malignant catatonia is a triad of those, catatonic features with hyperthermia and autonomic instability. All right, now to the fun stuff, the pathophysiology. Right now, like to understand it conceptually, the circuit model maps like onto this nicely. They're proposing it's the corticostriato-thalamal cortical architecture. And so that's like a loop that's central to how we think about movement disorders, basal ganglia, and treatments that go with that as well. So just a brief overview of this for this audience, but this neurobiological model involves three interconnected neurotransmitter systems. So we have the GABA-A, glutamate imbalance, and the dopamine hypoactivity, which kind of, again, maps nicely to when we think about treatments. With the GABA-A hypofunction, it's mostly in the frontal cortex and the striatum. This is the most established piece mechanistically, because reduced GABAergic activity in these prefrontal circuits is thought to dysregulate the motor planning and behavior output, which is what we see. And then the direct therapeutic implication, benzodiazepines, which modulates the GABA-A receptor, can restore inhibitory tone in these circuits. So that's why benzodiazepines are first line. Dr. Northoff this is a paper in Behavior and Brain Sciences in 2002, proposed that the echo phenomenon actually, so sometimes people can have echolalia or echopraxia, comes specifically from disinhibition of the mirror neurons in that orbital frontal cortex, which is a result of the GABAergic failure. So I thought that was interesting. So in the center here with the glutamate imbalance, it's proposed to be in the posterior parietal cortex. And this model is elaborated in the 2025 APA resource document, actually. And it proposes an increase in NMDA activity in that area alongside the frontal GABA reduction. So there's an excitatory inhibitory imbalance. So anti-NMDA receptor encephalitis is the clearest clinical illustration of this. And NMDA receptor antagonists can be helpful in refractory cases, though to be clear, they're kind of like adjunctive agents, but that's something we think about mechanistically there too. And there might be interneurons too that are having, again, that imbalance between excitation and inhibition with GABA as well. And then on the right, we have the dopamine D2 hypoactivity, and that's in the basal ganglia, our movement centers. So dopaminergic hypofunction is the direct pathway thought to impair the motor program selection. So like described as like cortical freezing sometimes. This is also why antipsychotics like since they block D2, can worsen or precipitate catatonia as well. So putting it together, and I'm not going to go over this in detail, but this is actually from the APA. This is what they have as one of their supplementary figures here. I thought it was nice if you want to dig into that more, is corticostriato-thalamocortical circuit. And again, it maps kind of nicely into what we know in terms of, or what we try to treat it with mechanistically too. So also, besides the circuit theory, there are some other models, and I just want to mention them briefly. So like evolutionary fear response. So like playing dead, kind of like a tonic immobility strategy, conserved from like early on, maybe like in evolution. So it's kind of switched on under extreme stress when somebody's under extreme stress. And then limbic dysrhythmia. So EEG can show diffuse slowing or resembling non-convulsive status epilepticus, and treatments overlap with seizure care. So like benzos or valproate is something we use adjunctively sometimes. And then also neuroendocrine or hypothalamic dysfunction too. And so the takeaway is that this system, like specifically the circuit system, it's a nodal system with a lot of points of vulnerability. And it's exactly why like so many maybe different insults from metabolic derangements, maybe autoimmune encephalitis, primary psychiatric illness can kind of converge on this one syndrome, same syndrome. So, okay, so moving nicely into etiology, it's kind of like, again, a final pathway, the whole range of psychiatric, neurodevelopmental, medical conditions that can funnel into it. And finding the underlying cause isn't just for completeness, it kind of shapes the treatment plan that go well beyond managing just the catatonia itself. So there's three broad categories to kind of look at. The psychiatric causes, mainly mood and psychotic disorders, are still most common. The exact split varies a lot by age, cohort setting. So there's not a single percentage I'm putting on it right now. But mood disorders, especially bipolar and MDD, have historically been the most common actually associated with it. And there's a good argument that mood-related catatonia was systematically underdiagnosed, and maybe that was just due to it being folded into that dementia precox too. Also neurodevelopmental, looking at that. So neurodevelopmental column is especially important for the patients we deal with for autism spectrum disorder. There was a 2021 systematic review in the European Psychiatry Journal that pulled the lifetime catatonia prevalence at approximately 10.4%, so 10%. And that was across like 12 studies, almost 1,000 individuals. And then in the medical and neurologic column, a lot has grown in terms of etiology recently. The anti-NMD receptor encephalitis was Dr. Delmo, and they wrote about it in 2007. And when a child's catatonia turns out to have a medical cause, as I mentioned earlier, Dr. Lichter's 2025 cohort, roughly 70% of those cases can be like an autoimmune encephalitis. You can also have non-convulsive status epilepticus, which is worth flagging because it can kind of look like catatonia, which is why we work together on these patients. And one thing to point out across all these categories is that antipsychotics can worsen catatonia and can precipitate even other emergencies like neuroleptic malignant syndrome when catatonia is active. So it's, again, something to make sure we're recognizing and that we're appropriately thinking about when we're doing a workup too. Also, I wanted to point out just a little bit more. I was doing some research and on the anti-NMDAR, the single best reference, I actually found Dr. Delmo's 2019 Lancet Neurology review, which had some nice figures in it, numbers. So about 37% of these patients are under 18, and so it skews young. And then also from it, he said roughly 70% develop seizures and abnormal movement show up to something like 95% of young children, actually. And the two triggers, remember, are ovarian teratoma and herpes simplex encephalitis. In about, at that time, what he wrote is about 80% approved with immunotherapy. And so I thought that was really interesting too. Another entity worth knowing by name, one of my colleagues talked about it actually earlier this year in our department, was Down syndrome regression disorder, a subacute loss of skills in adolescents with Down syndrome, insomnia, withdrawal mutism. And when you do one of our like rating scales, which we'll talk about next, like the Bush-Francis, essentially all these patients can meet catatonia criteria. The biology is kind of the striking part. Like there has been studies that show that there was like a lot of them. There was a 164 patient cohort found that autoimmune markers, so like positive ANA, low complement, elevated ferritin with these patients, and they often responded to immunotherapy or IVIG. So again, it's an example of maybe immune-mediated catatonia hiding inside a developmental regression. So that was interesting. Moving on to diagnostic rating scales. So recognizing catatonia is the first step, and then we want to try to confirm it, quantify it, make it kind of like systemic and like an evidence-based assessment so we can go through and treat it as best as we can. So I put up here the Bush-Francis catatonia rating scale and the pediatric catatonia rating scale. The Bush-Francis is the instrument that I've used the most, and I think we use in psychiatry. It's actually the instrument that the 2025 APA resource document recommends. It has 23 items in total, but actually only the first 14 are the screening instrument. And so you can even, they have this on MD Calc, but they also have materials at the University of Rochester Medical Center, so Dr. Oldham's group. They do a fantastic video series on this. We may have all seen this, and if not, if you Google it, they have Dr. Wartzel's there as the standardized patient, and it's pretty entertaining, but it's very helpful to kind of go over what the instrument looks like. The first 14 as a screen, they all capture the 12 DSM-5 TR criteria. So a score of 2 or more on the screening portion actually is positive and tells you to finish the full scale. So it kind of kicks it into that. And what sets the Bush-Francis apart is that it's the only catatonia scale that's validated against the lorazepam challenge, which matters because it lets us kind of document treatment in a standardized, kind of reproducible way. Dr. Smith's, he had a study in 2024, and the main Bush-Francis catatonia rating scale at presentation in pediatric patients was 15 plus or minus 5.9, so about 6. The pediatric catatonia rating scale addresses a real limitation of the Bush-Francis. It wasn't originally validated in children or people with neurodevelopmental disorders. So the PCRS was validated in 2016 using a developmentally appropriate language, and it focuses on how far a child has deviated from their own baseline and kind of leans more on caregiver collateral to catch regressions. It does have a Cronbach alpha of 0.67. I just put that there because it's kind of like multidimensional in terms of a syndrome. So you wouldn't expect maybe 4 distinct symptom dimensions to correlate highly together, which would be a higher alpha there. But it does have a receiver or an ROC under the curve, so receiver operated curve, like number of 0.983. So it's pretty reliable in identifying catatonia in pediatric patients despite the moderate alpha. Also in 2025, Dr. Lucarelli and colleagues published the catatonia quick screen. And I actually didn't know about this, so this was kind of new to me. But it's only 4 signs and it's a screener. So, and the 4 signs are excitement, mutism, staring, posturing. It was validated with the training cohort was about 500 patients, 446, 97% sensitivity, and an independent validation cohort had a sensitivity of 91%, and that was almost 1,500. But again, it's designed to rule out as with high sensitivity. So if you do get a positive on that, then you want to go ahead and pursue like one of these other scales too. So to walk through them specifically here, the Bush-Francis, each scale item is rated 0 to 3. And I think it's interesting the number 3 keeps coming up in catatonia. You want 3 of 12, and there's 3 DSM specifiers or diagnostics, and then this is 0 to 3. But each item is rated 0 to 3, and it's observed by severity. So there's a standardized exam to elicit these behaviors. And again, that's something that you can, University of Rochester has a really good training material on that you can, look at. But for instance, like gently repositioning an arm to test, for catalepsy, or maybe like waxy flexibility. And then with the PCRS, or the catatonia rating scale, the 4 dimensions capture clinically distinct parts of the syndrome. So like the negative withdrawals dimension, mutism, negativism, social withdrawal, which is kind of prominent in like our ASD populations. The echo phenomenon needs careful baseline comparison for those patients as well. And then again, with the CQS, or the screener, it's something you want to use as a rule out tool. So the workflow, as I was talking about, can be CQS to rule out, then you can do a Bush-Francis to confirm, and you can then, and that's traditionally what we use in psychiatry, the Bush-Francis, and then you can further do serial Bush-Francises to monitor the response to treatment, we'll talk about. This is also from the APA research document, resource document. I just wanted to put it on here because I think it's interesting. If you look at, here's the DSM right here. And so if we think about, this is just the column here, we have the 12 criteria here that the DSM wants to talk to you about, or says that you want to look at, and you need 3 of them for catatonia. But then when we look at these other areas, the Bush-Francis, here's the screening part, and then here's the full scale. There's more symptoms that can be present that we can see, or signs, I should say. And this is a nice chart that kind of shows you, again, after you've kind of gone over this before, is like, okay, what are some of these psychomotor activities that we observe versus elicit on exam? And I think it's just a really nice, helpful overview. Again, this is in the 2025 APA resource document. So moving on to diagnostic workup. On when to chase an autoimmune case, I will leave this up to my neurology colleagues, but really the triggers that should prompt an urgent autoimmune workup are that subacute onset over days to weeks. I remember a case when I just started consults here that kind of involved that, and psychiatric symptoms maybe coming on before the motor symptoms, abnormal, and then motor features, and then there's also seizures, autonomic instability, or maybe like the picture hasn't really responded to the benzodiazepines that we'd like it to respond to. The AP2 score, which is something that I learned about here, can help estimate how likely autoimmune encephalitis is. And again, I don't need to talk about that further. And then Dr. Lichter and colleagues, again, they talked about among children whose catatonia had a medical cause, 70% had involved autoimmune encephalitis too, in abnormal EEGs. The differential is broad, and so the workup, you want to get basic labs, and also some of this workup is going to include ECT workup, which we'll talk about too. And in terms of further diagnosis, the lorazepam challenge, which we use, is something that we can use to screen for, but also diagnose, or really diagnose as well. So once your workup kind of points you toward catatonia, the lorazepam challenge is how you confirm it. It's usually diagnostic and therapeutic at the same time. And this protocol here is actually from the 2025 APA resource document. So in adults, we usually give 1 to 2 milligrams, and then in children you can give, and usually it's IV, smaller dosages. And you do the Bush-Francis first, so you do the scale first, and then you'll provide the Ativan, the benzodiazepine, and then reassess within 30 to 60 minutes of that parental dosing, that IV dosing, or within 2 hours for oral. And a drop in 50% or more, and the score counts as a positive response. To put some like further weight on behind that, Dr. Lucarelli actually found that, again, this is a retrospective cohort in 2024, that the challenge brought the mean Bush-Francis down from, again, we talked about that 16.6 to 9.5, and the Hedges G, so that effect size was 1.2 for that. So that was showing a pretty big effect size. One caveat I'll state too is that sedation after the challenge isn't a negative result, because some patients with catatonia have a higher sedation threshold and will only show their response once they wake up. I had that happen once when I was working with adults, when I had like the teach service with me, and I was like, well, just went to sleep. But then it turns out later that maybe they just need a different dosing. If you get a positive response, we'll continue lorazepam as scheduled, and usually we schedule it every 6 to 8 hours, and we can transition to oral later after some stability on the IV or parental dose. If you get a negative response, take a step back, ask about what the diagnosis is. Is it right? Revisit the differential. If catatonia still seems likely, say maybe a child with a neurodevelopmental disorder, where maybe the response could be blunted, consider a re-challenge at a higher dose too. If there's no improvement after 7 days of adequate benzodosing and we're still thinking about catatonia, we can move on to something like ECT as well. And this is also from the research document. I thought it was just interesting for the differential here too. A lot of this is going to be talking about adults, Parkinson's disease, but it's just to keep in mind a broad differential here. So in terms of treatment, I already kind of hinted at it from the last slide here, but it's evidence-based. There's actually the evidence base for it, is that it's mostly observational studies in case series rather than randomized trials. The 2023 British Association of Psychopharmacology guidelines mention this. And so that's one of the limitations here when studying catatonia. But the direction of evidence is consistent. Is usually we're going to be doing benzodiazepines or lorazepam mostly first, and then we can move to ECT if it's, again, if we're dealing with only catatonia, no other medical issue. And when benzos aren't enough, maybe you can use adjunctive therapies as well. And so this is the slide that kind of shows what I was just talking about. Step one is that lorazepam challenge. And again, sometimes really the doses can get up to 30 milligrams a day. And this is something that even the first time I read about it, I was like, wow, that's a lot. But I've had patients, and most recently I had a patient that was on like 10 milligrams a day. And that kids with neurodevelopmental disorders like autism need substantially higher dosages sometimes. One thing for timing is that, and I don't think this is something that I do enough of, is thinking about ECT earlier, and maybe doing the workup earlier in that, because that is second line for treatment. And really the ECT, pre-ECT evaluation is like a history and physical. So you do an H&P and get baseline labs, which we're already going to be getting, and then anesthesia, preoperative clearance, and then pediatric consent and assent processes too. With ECT, actually, the bitemporal placement is generally preferred, and 6 to 20 sessions are commonly needed. And the FDA does recognize ECT for catatonia in patients 13 and older who are treatment resistant or need a rapid response. If those malignant features show up at any point, don't wait, start the ECT workup and maybe that process more urgently. Just want to touch on these like adjunctives here. Personally, we use a lot of time, we'll find that the AEDs, because there's a lot of like comorbid mood disorders, like Depakote can help sometimes, or valproic acid. And again, mechanistically, like the NMDA like antagonists can be considered, but they're usually like a bridge and not a substitute. And then with antipsychotics, again, this kind of needs like clarification here. The APA research document actually lists like lower potency ones. And again, this we'll talk about later guidelines, but like aripiprazole, olanzapine, clozapine are preferred based on their relatively lower D2 affinity. But quetiapine is also reasonable given its low affinity. And that's what we'll talk about. There's a 2026, like Samsel and others, they did a Delphi study that preferred quetiapine. But that said, the APA document notes that there's limited literature for quetiapine. And so antipsychotics are really when there's comorbid psychotic illness or maybe mood disorder, and always alongside the benzodiazepines, usually never an active, obviously malignant catatonia, or if there's an MS, you want to stop it. So I thought I'd touch briefly on ECT. I'm not an expert in it, but I think it's worth mentioning here because I think when we think about it, there's like maybe some cultural or like past history baggage, but it is evidence-based. The response rates in adolescents with catatonia like can run up to like 90%. And the FDA actually reclassified ECT in 2018, explicitly noting that's indicated for catatonia in patients 13 and older. In February 2025, ACAP put out a policy statement. That's our organization reaffirming that children and adolescents should have access to ECT when it's clinically indicated too. And part of that is because there are different states. There's some legislative barriers sometimes to getting this because there's no federal law about it. It's all locally driven. In Arizona, from my experience, and maybe others might know better here, at the end you can mention it, but Valleywise was something as a student when I rotated there, I got to see that. And then also I believe Aurora, when I was there, they have that as well too, and that's where Aurora Behavioral Health, that's in Tempe. If you're wondering about, sometimes it's like, where do I even get this? And those are two places you can get that. We talked about that bitemporal placement is generally preferred, and then maintenance is often needed as well. There was actually a study that Dr. Lugrelli's group, again, this was in 2025, and showed that like 14.5% ultimately needed ECT, and it was approximately 165 kids. So further, I want to mention too, because I think this is something we don't think about until it kind of lands on our service. But as I was mentioning, there's no federal statute on ECT. It's regulated by state. Livingston's 2018 review went through all 50 state legislative sites and found that 8 states had detailed restrictions here. Arizona sits toward more of the permissive end, but when I was doing a little bit of research, I found that Title 36, which kind of deals with our mental health here, or does deal with the mental health, is that it bars DDD from administering licensing or funding ECT for its clients. So, and so it's worth noting because, with DDD, it's, the eligibility includes like there's children with autism or Down syndrome, that's cerebral palsy, epilepsy, intellectual disability. And so it's a restriction on possibly like the state acting as a provider and funder, but it doesn't mean children enrolled over they can never receive it. And there's probably more to it than that, but there's just a little bit of nuance there too. And it matters too, because there are some case studies like children whose catatonia was prolonged and then complicated by, maybe a state law with ECT. All right. And then with the special populations, just want to note that, not special populations, but in medical complications, this is something that the medical complications can look a lot like critical illness, and so the management will kind of mirror the same. Cardiovascular is highlighted here. And again, with adults, you can get this more so with kids, but it's still like a real risk that you want to be able to think about. And the framework would be like maybe post-intensive care, like kids who survive this prolonged catatonia may face this long-term physical and cognitive sequelae. And they maybe need the same multidisciplinary rehab that we also give critical care survivors too. So for special populations, so this is from the APA research document, specifically patients with neurodevelopmental disorders may display a regression from baseline. And so that's what I want to point out here is the central thing to that is maybe regression. And that's a diagnostic challenge as well. This framework was laid out by Dr. Hoptman and others. They had a Lancet Psychiatry review in January 2023. 6 child and adolescent neuropsychiatrists who kind of specialize in this population proposed 2 ideas: the personalized score at baseline, the PSB, and an estimate of the child's premorbid neurobehavioral and motor presentation, and the catatonic deterioration from baseline, so the CDB. And these an estimate of what's currently due to catatonia rather than their underlying neurodevelopmental disorder. So it's the practical anchor again is changed from baseline. Catatonia and autism doesn't so much add features as take them away, maybe a new mutism in a previously verbal child, or loss of motor skills, regression in self-care. Those are qualitative changes, not just more of an existing behavior too. In terms of the biology, just to mention quickly, there is genetic literature emerging too. There's a 2024 case report that talked about first catatonia case in the SHANK1 variant. There's also earlier work linking SHANK3. And so it's still, this is still case reports in small series levels. And treatments are, again, benzodiazepines are still first line. And sometimes kids with autism need a higher dose as well. And there's even a 2026 review recently in Journal for ACAP, and it was a review of 227 studies that confirms higher dosages, longer durations are needed than neurotypical patients. And ECT has well-documented benefit in autistic catatonia or catatonia in children with autism. I just want to briefly mention the emergencies because these are real. So we want to make sure we remember these. Malignant catatonia is catatonic features with hyperthermia or autonomic instability, essentially with hyperthermia. And the management isn't sequential, it's simultaneous. We want to provide those supportive care, benzodiazepines as well. And then NMS can kind of be best understood as like a drug-induced malignant catatonia almost. And so that's, again, we're utilizing our psychiatry, we're working a lot with patients that have neuroleptics on board. And so that's something to think about. We're getting near the end here. So I just want to mention briefly, it's a fairly small, but it seems productive research community recently. And some of you may know some of these individuals, but I want to go over guidelines. Dr. Smith at Vanderbilt, we talked about Dr. Lucarelli here. There's others that have been co-authors in these guidelines. Dr. Oldham, he's the one that produces those videos at a University of Rochester too. Dr. Samsel and others had the first clinical consensus pathway too that we'll talk about. So for current guidelines, there's the APA resource document. So that was approved in 2025, and then the British Association of Psychopharmacology as well. And these, the APA document covers the assessment, like we talked about, treatment, even they have a pediatrics section. And then the BAP guidelines are the most comprehensive international evidence-based consensus on catatonia too. So in doing for the research on this, so before the first expert consensus pathway existed, Dr. Smith and colleagues at Vanderbilt created a pediatric catatonia clinical roadmap and published it. It came out of a deliberate multidisciplinary team. So it was like child and adolescent psychiatrists, rheumatologists, neurologists, pediatric hospital medicine, pediatric psychology, and they met regularly from 2022 to 2024, reviewed literature, reached consensus on 5 clinical domains, and published their work. You can look at it further if you want, but this is just what they came up with. And it talks about a lot of, obviously we talked about the lorazepam challenge here. We're repeating it, and then here's the lorazepam challenge, clinical criteria for AIE. I thought it is very informative. And then out of that, we have, this was actually from earlier this year. So this is Dr. Samsel and others, a Delphi study. So they used the Delphi methodology, and they had 15 child and adolescent psychiatrists across 14 institutions where they have those iterative rounds of surveys with a consensus defined as more than 70%. And so 3 findings of the consensus findings I just wanted to point out was there's no maximum dose. And this is from, this is a figure from the study. There's no maximum dose for lorazepam when ECT isn't available. Keep titrating until side effects appear, you get enough improvement. Second, ECT should be pursued for kids with partial or no response to lorazepam, regardless of how accessible ECT is. Third, among low potency antipsychotics in stable presentations, YTAPine is specifically preferred. So I thought that was interesting because we were talking, antipsychotics again are something we don't want to do just rashly. We don't want to throw them around. Future directions. So I think really what I want to point out is randomized controlled trials would be nice to have. That's the single biggest gap, the lack of those controls, because a lot of what we do is extrapolate from adults in case series. The biology side, there's NMDA antagonist trials, biomarkers, genetics, also neuromodulation as well, which I briefly have here to talk about. The rationale is actually that in the pre-SMA, the supplementary motor area, and the SMA, they appear hyperactive in catatonia. So the inhibitory, like TMS of the left SMA is a logical target. And then obviously ketamine is an NMDA antagonist too. But really the data, or I guess the literature here is it's like case series, and there's not random, it's experimental, not randomized controlled stuff like trials. So it's more mechanistically grounded. So key takeaways from today, it's a treatable emergency, and we don't want to miss it. We can diagnose and validate with a scale, so our Bush-Francis. Always kind of think about it, when there's medical cases, and 70% of them can involve autoimmune encephalitis, and anti-NMDA are the most common of that. Benzodiazepines are first treatment, ECT is second. Neurodevelopmental group is a high-risk group, and we always want to remember, like when you think about ultimately like the most pressing or severe catatonia can be life-threatening malignant catatonia. So with that, those are my references, and I just want to say thank you.
Thank you, Dr. Broderick. Such an interesting topic and an interesting talk. I was wondering, you're saying we have such a major gap regarding randomized controlled trials. How would you propose setting up a trial that is ethically sound, given the robust response, the treatment response to currently available treatments?
Thank you, Dr. Riffield. So that's a good question. I think it's difficult because obviously these presentations aren't something that we can source ahead of time. But I would think about, and we can involve probably multiple services, and somehow try to implement one of these protocols and turn that maybe into a randomized controlled trial. I'd probably lean on some of these guidelines to do that. And then hopefully be able to piece together something like that.
I think perhaps one way would be instead of having a placebo-controlled trial, which I think would be hard to get through any IRB, knowing how effective benzodiazepines are, and some of these kids may not be eating right. To give them a placebo in those settings would just be um, unethical. Um, a setup where you compare first-line benzos with first-line ECT, for example, might be something that would be able to get through it through an IRB.
Yeah, actually, yeah, that would be, and it's with ECT that might be, again, that's the difficult part, and I think that's a great idea though. Yeah.
If no further questions, I want to thank you very much, Dr. Broderick.
Thank you. I want to thank everyone for being here today, and I guess, have a good happy Monday. It's June 1st. Have a good rest of the week and month.